Today I'll tell you something which is I'll start with something that how we have started this lecture series. Few months back, I discussed with Naveen that Naveen we should start some kind of a lectures for our MD students all over country. And then we thought that it's not MDs which you who needs recent updates in various topics. I think we should extend it to the all youngsters, those who have started palliative medicine program or palliative care program in their hospitals. And then we just thought that no, it's not necessary that only they need this kind of a structured training or recent updates on various topics. Let's make it for all over India. And finally, we have started. And then I asked Naveen that Naveen, please make the important topics list, that what should be and who should take the topic. And Naveen has formulated such a wonderful program that every time we hear something new and we think that it's going on in absolutely in a structured way and it's in a coordinated way. So since the inception of the program, we keep thinking that this is such a wonderful program, and all the topics which are important have been covered till now. This was ultimately formulated by Naveen. So I think, and when I saw that Naveen has kept almost in the last his lecture, but it is although it is in the last, but it is almost a very, very important topic. I think when it comes to delirium, we get a lot of patients in delirious condition, and it is always a dilemma that how we should approach, and the who can tell you better that to approach a patient who is in delirium better than Naveen. I think there is no need to introduce Naveen. I don't think that out of 72 already have joined, that Naveen, I think Naveen is familiar word and everybody knows Naveen very well. But still, Naveen has is a true palliative care physician. He did his all sorts of degrees, including from FRCP from London, and diploma palliative medicine from clinical diploma palliative medicine from Australia, and MD from Manipal. He has started MD palliative medicine program initially in Tata Memorial Hospital, and now he is heading the Department of Palliative Medicine in Kastuba Medical College, where we keep hearing a lot of good things. Every day they are developing. They are starting renal palliative care program and other ICU palliative care program, and I think they are developing in a structured manner. Truly a Department of Palliative Medicine at Manipal, Kastuba Hospital, Medical College and Manipal. And he is also now is going to be the chief editor of Indian Journal of Palliative Care. I think he has joined 6 years back IJPC with me, and since the day he has joined, I don't think that I have been anything. I mean, like there was no worry at all since the day Naveen has joined, and he's took over so nicely IGPC. And Naveen, we are really proud of you. I think there are a lot of things, and sometimes words are not. I don't have words to describe Naveen's CV, but Naveen, you please continue how to approach a patient who is delirious, because I get overwhelmed whenever I talk about Naveen. So continue, Naveen. Please listen to, and I want that all MDs should listen again and they should ask question if they have regarding delirium. Thank you, Naveen. And Arun will keep the track of all the questions, and we will ask the question at the end.
Yes.
Good morning, everyone. Thank you, madam, for that very generous introduction. And thank you for the IAPC for providing me with this opportunity to present on the topic of delirium. I'm not a psychiatrist nor a neurologist. So truly, I'm not an expert on delirium, because it is primarily the domain of psychiatrists, psycho-oncologists, and neurologists to speak on delirium. But whatever little I know or I understood about delirium, I will share my views. So I'll start with the sharing the screen. Uh, And so this week is the Christmas week, and we're all in the cold Christmas mornings. And I'm thankful for almost 80 plus participants who preferred to be awake and join this meeting uh, on this time of the year and the day. Probably I would have been preferred to do the otherwise, to sleep further and not to wake up on the cold mornings. But a lot of people are very motivated, and it's truly nice to know that. And as we spoke about this season, which Madam had spoken, this is the last but one episode of the season one of the IAPC Academy of Palliative Medicine. It's the penultimate episode. The last one would be done by Dr. Raji, who would speak on end of life care. And delirium often appears before dying. So probably it all played out well, and the delirium topic came just before the end of life care. And for all the people who are Game of Thrones fans, the penultimate episode of Game of Thrones was called The Bells, where the Dragon Queen, what we call, became mad and did a lot of things. And whether the tolling of bells made her mad or made her delirious, we will never know. But it is a topic, it's very enigmatic topic, and so many things keeps changing in this topic. There are so many controversies, so many new things keeps emerging. I have interspersed a lot of what we already know, and what are some of the things that are new in this topic as I will be presenting. So before we talk about delirium per se, we always need to understand what consciousness is. And I often use this as an example. And actually, this example was taught to me during my training by a psychiatrist by name Dr. Rajan Nagesh, who was the psychiatry liaison for the palliative care during my training times. And the simple analogy is the radio. So if you see the old transistor kind of radio, it usually is to have only three buttons. So that is the on and off button. There is a volume button and there is a tuning button. So on and off button is equivalent to either you are awake or sleeping. So for example, you are listening to this lecture and you might have on your computer, but you may be fast asleep. So the first part of consciousness is wakefulness or being awake. So that's your on and off button. The second part of the thing is alertness or attention. That's your volume button. So you can increase or decrease. And the third part is the awareness button. That's the tuning button. So you may be awake during this lecture, but you may not pay any attention to that. So that's your alertness. So you may be awake, you may be very alert, trying to pay all the attention, but you may not understand whatever I'm saying, or I'm not being very clear. Then you are not aware of that. So before we understand or talk about delirium, we need to understand what consciousness is. And consciousness is made of three important parts, that is the wakefulness, the awareness, and the alertness. And I'm emphasizing it because when we are going to assess delirium, we are going to assess these three parts of delirium. And most of the time, if you understand delirium this way, you would not forget or you will not make mistakes while you're assessing delirium. So what causes delirium? So delirium is a it's not a single cause. It could be multifactorial causes, and people can have more than one causes which is running synchronously. So if we look at a 2020 publication by Siller et al., which talked about predisposing and precipitating factors for delirium in a palliative care setting. So I have deliberately kept the topic of delirium limited to palliative care setting. And if you look at what are the predisposing factors, and I highlighted some which were statistically significant. It does not mean that others are not significant or not contributory, but others were not found as statistically significant. Like definitely older age uh, increases the risk of delirium, but certain other things like male gender, frailty, impaired hearing, impaired sight, presence of cancer, presence of especially primary or metastatic cancer in the brain, in seizures, and other many conditions predispose the person to delirium. Now, why we should know the predisposing factors? Suppose you have a patient who gets admitted with you or in the hospital. If the patient has this predisposing factor, you need to be very mindful that this patient could develop delirium in the during the course of hospitalization. It's important to know that the hospitalization or being admitted in the ICU increase the risk of delirium. So if you understand there are predisposing factors, a person with this predisposition are more susceptible to develop delirium when they are hospitalized. So it's very important to know what are the predisposing factors. Likewise, there are certain precipitating factors. So what precipitates delirium? And as I said, these are the highlighted ones are the only ones which are statistically significant, like sepsis, presence of pressure sores, presence of renal failure, and uncontrolled pain always precipitates. But at the same time, we often know that an electrolyte imbalances, raised intracranial pressure, uh, other causes like hepatic failure, renal failure, all of them precipitate the delirium. So it's important to understand both predisposition and what precipitates delirium. And this is another paper which was published in 2017, again in a palliative care setting. And the highlighted greens are the one which do not cause. But if you see the others are the one that often causes. So opioids in excess, benzodiazepines, steroids that what we use, certain anticonvulsants, especially gabapentinoid groups and gabapentinoid groups, and infections, um, organ failures, electrolyte imbalances, sleep disturbances. So there are multiple causes that leads to delirium. And also, this is another paper by Sebastiano Mercadante, which is published in Supportive Care in Cancer. That is prevalence of delirium in advanced cancer patients in home care and hospices. And if you look at that, and one of the important thing what they identified is an excessive dose of opioids, corticosteroids, and certain conditions, drugs and conditions, increases the risk of delirium. So, why we are spending time about knowing the causes? Most of the time, there could be certain reversible causes of delirium, and there is an emerging evidence right now which says that reversing the causes of delirium is the best way to manage delirium more than the antipsychotics that what we often prescribe. So it's very important to understand the reversible causes of delirium. So this is just in compilation. Again, this image was taken from a review article. And if you take all the things into account, cancer per se, there may not be any one cause. per se could cause the paraneoplastic causes of cancer also, intracranial disease, primary or secondary brain tumor, dyslipidemias, organ failures, infections, sepsis, medications like opioids, anticholinergics, corticosteroids, chemoradiotherapy, and a lot of withdrawal, like patients is on benzodiazepine or patient was taking alcohol and sudden withdrawal of them, all could contribute to delirium. So, what is the prevalence of delirium? That what we see, and if we look at the prevalence of delirium, this was a systematic review which was published in Palliative Medicine in 2019, and those circles, whatever that you are seeing, are the various studies. So, like if you see the during admission, the prevalence could be less than 10% or to be more than 40%. Various studies have shown different prevalences. Uh, and if you go up here, the prevalence during death almost goes up to 60 to 90%. The rule of thumb, which is used, is prevalence is less than 1% at home, 30% on hospitalization, 60% on ICU admission, and almost 90% during end of life. That is a very rough general rule of thumb. So less than 1% at home, up to 30% on hospitalization, up to 60% on an ICU admission, and almost up to 90% before end of life. So every change or every transition of the patient from home up to the end of life, the percentages or the prevalence of delirium keeps changing. So, home is the best place where they have least delirium. The least delirium because it's the most familiar environment or the familiar surroundings. Moment that people are out of those familiar surroundings, it significantly increases the risk of delirium. So, it's important to understand these prevalences when we manage the patient. This is another paper which I found interesting, published in Supportive Care Cancer in 2015, led by the MD Anderson team, is that the frequency of missed delirium uh, among those referred to palliative care in a cancer center. So one of the important or very highlighting finding was that 61% of the patients with delirium uh, is often missed when they are referred to palliative care. And it goes with the statistics which says that two-thirds of the delirium are often missed. And people use a lot of varying terminologies to describe delirium. They call it a psychosis, altered sensorium, agitation, but all coming under the umbrella of delirium. And delirium is an organic brain syndrome with its own risk of mortality. Uh, so, an undiagnosed, untreated delirium significantly increases the risk of both mortality and morbidity. So, that's why it's very important to pick up delirium early. Yeah. And the other important finding in this paper was that patients referred for pain were more likely to have missed delirium. So it was um, uh, people thought it was an uncontrolled pain when it was actually delirium, and a lot of them had opioid-induced neurotoxicity. So people have thought that it is an uncontrolled pain and probably kept increasing the doses of opioids, and which probably complicated the whole situation. So it's important to understand these things, because your oncologist or the other specialist who are referring to palliative care may not truly understand or able to diagnose delirium. So, what is the pathology? So again, it's a very complicated pathology because we have subtypes of delirium, that is the hyperactive type and the hypoactive type and the mixed type. And there is a slight change in pathophysiology. Now, if you look at the hyperactive delirium, usually there is an excess of dopamine and a deficient of acetylcholine. And most commonly, what you see are the hyperactive types in your clinical practice. And the hypoactive types you do see, but it's usually difficult to recognize, and you may require an expert psychiatrist to pick it up. Uh, but there is this change in pathology is because of the deficient dopamine and excess of acetylcholine and excess of GABA. So I'll focus more on the pathophysiology of the hyperactive type, because that's the more common type that what you see. And if you see again, it's not just acetylcholine or dopamine. There are a lot of other mediators that causes the delirium, and it could be cholinergic, both inhibition and activation, dopamine activation, steroids, especially that what we commonly use, serotonin deficiencies, and serotonin activation, like similarly, cholinergic activation, inhibition, serotonin activation, inhibition, GABA activation, cytokine excess. So it depends upon the cause. Again, it takes a different route to cause delirium. So it's not just acetylcholine alone. So a lot of time people think in terms of mainly in terms of acetylcholine and cholinergic pathway for delirium, but it's not just the cholinergic pathway. So there are multiple pathways that are there which are acting either independently or synchronously together. So it's important to understand all the pathophysiology that could potentially contribute to delirium. And this is just a table which shows the spread of various neurotransmitters and the various conditions and how it often contributes. It's a busy slide, but it's important to understand the complexity. It cannot be reducible to one neurotransmitter and say it's acetylcholine and we are going to reverse the acetylcholine part. It's just the many things that are happening together. This is an interesting paper that I thought we should discuss. Is which is published in Palliative Medicine, which talked about increasing anticholinergic burden and delirium in palliative care inpatient. And there is a score that is being used called as an anticholinergic risk scale score, ARS score, and it depends upon the anticholinergic drugs that what we use. And like for example, there's a point system like 1 point, 2 point, and 3 point, and certain drugs which are in the 3 point have a higher preponderance of causing delirium compared to the drugs that are in the 1 point. Mm. So like amitriptyline and other drugs that are in the 3 point system. There's also an important paper which again opens a lot of controversies, is the plasma cholinergic enzyme activity and the risk of developing delirium in palliative care. And whenever the ACHE levels, that is the anti-acetyl ACHE levels, how it correlates with the delirium. And what it showed is that the number of anticholinergic medication, because we always think that, okay, more number of anticholinergic medication, higher the risk of delirium. But that part was not established, because even a single anticholinergic drug could cause the same amount of delirium as more than one anticholinergic drug. So it's important to know that part also. It's just one drug itself that could contribute to that. And if we look at what is the clinical presentation of delirium, so this is probably an easiest understood way. And this sequence I got from a review article which is published in New England Journal of Medicine. And delirium goes through a sequence, and not necessarily in the same way, but more often the same way. So usually it starts with a sleep cycle disturbance. So the person may be sleeping more during uh, the day and not sleeping at night. So that's usually the common presentation with which they start. And this sleep disturbances usually proceeds with the change in the affect and mood, where they can become more irritable, more anxious, angry, paranoid, fearful, and then there is some degree of loss of attention or disorientation, where the orientation to place, person, time, and difficulty in maintaining attention, leading on to disorganized thinking in speech, everything. And then the psychomotor part, where the person becomes very agitated, restless, or the hypoactive, very quiet, and leading to this changes in the consciousness part, where there is a dip in the consciousness and leading to an altered sensorium or coma. So why the sequence is important to know is that we need to pick or identify delirium not when the person is in coma, but better to pick it up quite early in the day when there is disturbances in the sleep-wake cycle, or whenever there is a change in the mood and the initial parts, because it's easier to manage that way. And also there are a lot of conditions that could closely mimic delirium, uh, like dementia, depression, and psychosis. So we need to be very mindful of the various aspects and how closely it resembles the other condition. So attention is something that's very important, and inattention is a very important part of delirium. But sometimes it is not that it is not present in other condition also. It could be present. So main thing that is a hallmark in delirium is an acute change in attention and altered consciousness. So we can't just take one clinical feature and say, okay, this is what it differentiates from delirium from other conditions. We need to consider all the clinical features together, and then only you'll be able to differentiate delirium from other conditions. So it's very important to be mindful of this thing. This was another paper which was published in 2018, which looked at occurrence of agitated delirium during the 24-hour day. And if you see here in this diagram, the episodes of agitation, usually after 6 o'clock, 8 o'clock in the evening, peaking to at around 10 o'clock to midnight, and post midnight till almost till 6 a.m. So this is very consistent with the history the family members give us whenever we do the ward round. They say that person was very agitated in the night and did not sleep at all, and that's how they normally behave. That the agitated delirium, the peaks more in the late evenings and in the night, especially around the midnight and early mornings. So it's important that we give medications in a way that covers these episodes, especially at the night time. Also, it's not just the clinical features of delirium alone. This was another paper that was published in 2019, the oncologist, again by the Sebastiano Mercandati team from Italy, which explored what is the impact of delirium on other symptoms, and especially they looked at various ESAS scores. And delirium has an influence on multiple symptoms, presence and experience of those symptoms, its intensity of the symptom, especially if you look at pain, fatigue, and other certain symptoms, it is statistically significant. And also, although those which are not statistically significant, also there is quite an impact. So it's has a huge role in both experiences of other symptoms, not just the symptoms of delirium, but also it has an impact on the experience of the other symptoms. And going forward, as the delirium progresses, it also has a huge impact on symptom reporting. So imagine the person is in altered sensorium, then the person may not be able to report the symptoms. So, how to screen and assess delirium? So, so we're going back to the radio, that what we saw, and the three components. So you have to assess the alertness, awareness, and the wakefulness, which is the consciousness. So we first look into the consciousness part and then look at the content part of the consciousness. So we have to look at both of them when we assess the person for delirium. So consciousness, we use a Richmond agitation sedation scale, also called as the RAS scale, where why this scale is important is that this helps in uh, knowing what is the outcome of our therapy. Our aim is to achieve zero. Zero means alert and calm. Anything that is in minus is where the person is more and more sedated, and anything in the plus is the person is getting more and more agitated. So -1 to 3, it is from drowsiness to moderate sedation, and -4 to -5 is a form of deep sedation. Whereas +1 to +2 is more of restlessness and agitation, and +3 to 4 is severe agitation and violent behavior. Yeah. So it gives us an idea of where our patients are at. Uh, and it's good to document the RAS scores uh, every day in our rounds, especially in patients with delirium. When we talk about vital signs, the nurses probably will talk. We always talk about signs in terms of respiratory rate, pulse rate, blood pressure, and temperature. So when we talk about vital, we always take cardiopulmonary as the vital signs and vital organs. So that's why they introduced what is called as a brain rounds, where they think that this what's happening in the brain is also very vital for the patient, and this is often not understood, especially the how to assess the consciousness in terms of the RAS. And also we need to look at the content of the consciousness. And I'll come to various other methods, both screening tools and tools to assess the severity of delirium. But the content, there are four features: feature 1 to feature 4. Feature 1 is an acute change or fluctuating course of mental status. Feature 2 is inattention. Feature 3 is altered level of consciousness. And feature 4 is disorganized thinking. So these are the four features that we assess when we assess the content of consciousness. So what does feature 1 means? That is the acute change in mental status with a fluctuating course. So there are certain subjective things where you ask, and there are certain objective things which you notice and identify. Like you ask the patient whether they've experienced that they've been confused in the past day, they don't know where they are, or they don't know that they are in the hospital, they're seeing things that are not really there. And you observe and see whether there are fluctuations in the level of consciousness, fluctuation in attention, fluctuation in inattention. speech or thinking. So this is the feature one, where this acute change in mental status with a fluctuating course. There are also the second feature is inattention. So where you ask patients to do the following, like digit span, counting digits backward, days of the week backward, months of the year backward. This is what you ask the patient to do. But during your clinical consultation, you see when you are talking to the patient whether they are able to hold that attention speaking to you, whether they become easily distractible. So this is a second feature, which is inattention. And the features 3 and 4, where the thinking becomes disorganized. Like you ask the patients to state the following, right? The year, the day of the week, or the place where they are. But you notice whether the flow of ideas or the flow of thoughts is very clear or illogical. They go from one subject to another subject, or they may reply completely something that what you asked, and other thing is the altered level of consciousness. So it's very important to identify the level of consciousness and the content of consciousness. And we're talking about various tools that are there. This is a paper which was published in BMJ Supportive Care and in 2020. And what it showed was that the clinician worldwide often use more of clinical judgment to screen and diagnose delirium rather than tools. There are many tools, as I said, to screen and to know the severity of the delirium. But clinical, so it's we have to be clinically wise and be able to pick up delirium by clinical assessment, because although other investigations, either blood investigation or a functional MRI or EEG, may contribute certain aspects of a delirium assessment, but delirium is primarily a clinical diagnosis. So it's important to have a good clinical judgment while identifying it. These are certain other papers that looked at comparing various tools like revised delirium rating scale, which is, and MDAS, that is Memorial Delirium Assessment Scale, which are quite commonly used. And if you look at items of the DRS versus MDAS, most of the items were found to be very comparable. So it's important to know that also. And there was a comparative study between DRS and MDAS showed it was quite comparable. Both the scales were quite comparable. And when we looked at the practical assessment, you see, the screening tools are the CAM, which we just talked about, the 4 features. The confusion assessment method, which is a feature 1 to feature 4. But there is also the scales called as a nursing delirium screening scale, NUDESC, which is quite popular. And it's popular because it takes a very short time to use this scale compared to other scales. And there is also a single question in delirium. These are the screening scales for delirium. And there are scales to assess the delirium severity. The scales which I just talked about, the DRS, the delirium rating scale, the Memorial Delirium Assessment Scale, MDAS, are mainly are the severity scale. There's also a scale called CTD, which is the cognitive test for delirium, especially used in the research setting. And these are the comparative representation of the various scales in terms of consciousness, cognition, onset course, and the effect. And you see, DRS and MDAS are quite comprehensive in those assessment, especially when we assessing the severity of the scale. And all these papers have been published under SUNDIPS, say which was a special section of studies which were conducted to understand delirium in palliative care setting. Why I'm emphasizing palliative care setting is the deliriums in other setting, the management is probably slightly different. And so it's important to understand the delirium more in palliative care setting as we are talking. And if you see here in this paper, this is a very popular paper, and a lot of them have done the researchers in this paper, especially Meera Agar and other colleagues of hers who worked on the Sundips have found that there are 26 delirium scales which are there, but especially the confusion assessment method, the nursing delirium scale, and a single question delirium questionnaire are the scales best suited for screening. The revised delirium rating scale and the memorial delirium assessment scale are the best available options for monitoring severity, and the cognitive test for delirium is best used for research purposes. From also there is this is another study which looked at adding delirium to palliative prognostic score. So it was published in European Journal of Cancer in 2015. And how does, because delirium has got a prognostic value also. And if you see, if we add delirium to the palliative prognostic score, it improves the sensitivity. So especially in short survival, that is when we're talking about in terms of days, it has got a role in improving sensitivity, both in the hospital patient treated at palliative care unit and in home care setting. That delirium, presence of a delirium changes the prognosis. So addition of delirium to a palliative prognostic score, it could become more sensitive. But this same results was not occurred in a longer survival. That is, when you're talking in terms of months and weeks. So for a shorter survival, definitely an addition of delirium has improves the sensitivity. And now coming to the last part of it is how to manage a delirium. So this is another paper that was published in 2015, again by the MD Anderson team. And some of the parts of this I have already discussed, as that 58% of patients in an acute palliative care unit had a diagnosis of delirium. So as I said, so the rule of thumb is less than 1% at home or community, 30% on hospitalization, 60% on ICU, and 90%. But they found higher rates of delirium on admission. And patients who got admitted to palliative care also without delirium, also 29%, is almost less than one third developed delirium after admission to palliative care. Only in one fourth the delirium got completely reversed, and half of the patients with delirium died. So patients with diagnosis of delirium had a lower median overall survival than without delirium. And also patients who developed delirium after admission also had a poor survival and lower rates of delirium reversal. So why it is important before we go in for management is presence of delirium per se is a harbinger of an increased mortality. So it's very important to when we communicate with the families, it's very important to talk about it. And the seven principles, what we call about of managing delirium, is the first and foremost is the prevention of delirium, the primary prevention. So we talked initial part of our presentation with a lot of predisposing factors and precipitating factors. So if we identify people with the predisposition, that is people who are elderly, can't speak, can't hear, having mobility issues, and other predisposition, we probably have to be quite active or proactive in these patients to prevent an occurrence of delirium. And safety is very important of delirium. And I would like to quote an example of just when we talk about safety is that many years back, during my training days, we had a person with the delirium who was already on a haloperidol infusion in the ward, and suddenly became very agitated, and he took that syringe driver and hit the nurse with the syringe driver. So it's not just the safety of them, it's also the safety of others, isn't it? Sometimes they exhibit quite a violent behavior. So trying to identify the predisposition, at the same time having mechanisms that ensures the safety of the patient and the safety of others. We talked about various precipitating causes. So correcting the correctable is the very important thing, providing relief of the symptoms, and having a lot of environmental and psychological strategies, mainly non-pharmacological strategies, and coming to the pharmacological treatment. So these are the seven principles of managing delirium. And this is an algorithm that is commonly used for managing delirium. And I'm not going to all of them. So if you look at on the left side, that is the important thing is to do the correcting the correctable is, and also the environmental strategy. So making sure that the patient is hydrated properly. Pressure sore increases the risk for delirium. So the skin care, avoiding physical restraints. Physical restraints could paradoxically worsen delirium, and having a mechanisms to normalizing sleep-wake cycle. So having an exposure to daylight in the morning, uh, uh, less bright lights at the night, and a lot of environmental strategies where we require a lot of reorientation techniques, telling them where they are, which place it is, uh, talking them about the day, date, month, everything, looking for any potential drugs that could be causing it. uh. So why this algorithm is important is, this antipsychotic medications comes last. And what we do in our clinical practice is we disregard all the above and go with the antipsychotic medications first. So, and I would like to state at this point is that evidence for antipsychotic medications in a palliative care setting in patients with delirium is now becoming questionable with a lot of controversies. So I think we have a lot of work to do before we come to antipsychotic medications. So that's why this algorithm is important, because the considering trial of antipsychotic medication comes much later in the day if you see this algorithm. So pharmacological treatment, I would rush through some of these slides because I'll be sharing these slides about typical and atypical antipsychotics, and the dose that what we use of haloperidol is very small compared to what is used in psychiatry practice. And low doses of haloperidol is what is commonly indicated in delirium compared to high doses. So the chances of extrapyramidal syndromes and QT prolongations are much less. And these are the various drugs. You can read this in the slides that what I share, because I want to go on to other things. So these are some of the drugs that we use. We need to also consider delirium at end of life, because 80% of 80 to 90% of the patients could have delirium before they die, and it certainly impedes communication and symptom reporting, ability to participate in decision making. And family will get very distressed to see someone of their loved ones being so agitated and so restless, and caring for those people become very challenging. And also there is a concept of terminal delirium where patients are very agitated at the very end of life, and some of these are not amenable for managing with just antipsychotics, and they would probably need a palliative sedation in terms where you need an escalating doses of first line drugs like midazolam or levomepramazine, which is not available in India, and or phenobarbital or propofol, uh, where you continue the antipsychotics, but you also add these things for managing terminal delirium, because patients care could be so restless and so agitated, and it's very distressing for the family and also for the patient. So terminal delirium would warrant a palliative sedation if the agitation becomes unmanageable. Now, looking at certain papers and controversies regarding management of delirium, and this is a paper which was published this year, which looked at delirium rates in different palliative care settings. And if you see here the Kaplan-Meier survival curves, the course of delirium was different in a hospice versus an acute palliative care unit. The course was different because the reversible causes were better managed in an acute palliative care unit compared to that of the hospice. So if you see the in a hospice, people lived much shorter because there were little emphasis on correcting the correctable, whereas in an acute palliative care unit, people lived longer because they were correcting the corrective. So it's an important evidence again that in delirium that correcting the correctable is very important. This is another paper that was published again in 2020, which looked at effectiveness and adverse outcomes of antipsychotics in a palliative care setting. And what they found is that although there are a lot of studies coming about the questioning the role of antipsychotics, antipsychotics were found effective in people with 75 years, ECOG less than 3, with a clinician prediction of survival either in weeks or months, especially in the hyperactive type. It was more useful, and quetiapine among all the drugs was found to be most beneficial, and people treated with by the psychiatrist or the psycho-oncologist did much better than those who were just treated by palliative care physician. And adverse outcomes, extrapyramidal syndrome, urinary retention was seen in a very small person, less than 1%. Understandably, sedation was there, and probably it marginally increased the risk of aspiration pneumonia, probably secondary to the sedation. Also, the other papers that looked at, again, this was another 2020 paper, which looked at effect of antipsychotics and non-pharmacotherapy for management of delirium, again in a palliative care setting, which didn't support using antipsychotics and actually showed a poorer outcomes with an antipsychotics. And the message that came out from this paper is that have an individualized delirium management plan. You can't have a very generic plan giving antipsychotics to everybody. And reversibility is the key. Prevention is very important. Recognizing predisposition is very important, the precipitating cause. A non-pharmacological treatment was very important. And if you see here in this Kaplan-Meier curve, people with antipsychotic therapy lived shorter than without. Probably because those who were not receiving antipsychotic treatment received other treatment, that is correcting the correctable, or they were had a lot of primary prevention and non-pharmacological treatment. We don't know about that. There's another paper which looked at comparison of haloperidol and non-haloperidol and no pharmacotherapy. Again, this paper did not support use of antipsychotic. It's a 2018 paper which is published in Journal of Pain and Palliative Care Pharmacotherapy, which again emphasized correcting the correctable and non-pharmacological treatment. This is an Lancet Oncology paper which was published in 2020, which again looked at various neuroleptic strategies for terminal agitation in patients with cancer and delirium in an acute palliative care unit, which is a double-blind study, and there are three groups, what's called as an escalation group, the rotation group, and the combination group. And the escalation group had a 2 milligram haloperidol starting, which was escalated every 4 hours. And the rotation group had an alternating 2 mg haloperidol and 25 mg chlorpromazine being alternated. They started with the premise that 1 mg haloperidol is equivalent to 12.5 mg of chlorpromazine. And the combination group had 1 mg haloperidol and 12.5 mg chlorpromazine. And what they found is that the rotation group had better outcomes, where haloperidol and chlorpromazine was alternated, had better outcome in terms of delirium management in an acute palliative care unit. Our traditional teachings always has been avoiding benzodiazepines in a delirium setting. But this is another paper which looked at lorazepam and haloperidol in agitated delirium in a palliative care, which was published in JAMA in 2017, which said that the agitated delirium was better controlled when benzodiazepine were added and the RAS score. So again, if there is a presence of an agitated delirium with a higher RAS score, I think there is some role for benzodiazepine along with haloperidol. This is a systematic review which was published in 2019, which looked at the host of non-pharmacological treatment, which looked at primary prevention, identifying predisposition. Again, the evidence is not very robust in terms of all these interventions that are there. I think probably individual items probably need to be assessed in more detail and studied in more detail. So thank you for your kind attention, and thank you for the opportunity. I'll stop sharing my screen. Yeah, looking
Chat,
at the
yeah.
chat box. Yeah. So one was, by grading delirium, can we modify our medication? So the purpose of medications that what we use is to reduce the severity of the delirium. It would not, it's not a treatment of the delirium. It only reduces the severity or the symptoms of the delirium. So there could be a role by knowing the severity and titrating the medications. Yeah. Uh, I think most of the other things that I have answered during the presentation, and I will share the PDF version of my slides. Yeah, yeah.
Abhi. Arun, is there any other question?
How long can we continue haloperidol? There is a question.
Yeah. So again, there is no right or wrong answer how long we can continue. It's based upon the outcomes that what you see. And there are some patients we have continued for just couple of days and the severity had come down. And at the same time, you are working towards, for example, we recently had a patient who had a combination of dyselectrolytemia, sepsis. So moment you corrected all of them, that itself brings down the delirium. So your requirement for haloperidol comes down drastically. But if there are not many reversible causes that could be identified, or reversibility is not possible. For example, a person with a leptomeningeal disease where there is no scope for further chemoradiotherapy and the person is delirious because of that, you may require to continue haloperidol for a much longer time. So, yeah.
Okay. Sir, Dr. Hasina is asking about this feature 3 and 4 in those original 4 features. Can
Yeah.
you give an example of 3 and 4?
So, the first feature was, one is an acute onset and fluctuation course, and feature 2 is inattention, and the feature 3 is disorganized thinking. So when you talk about disorganized thinking, is that when we are asking the patient a question, they probably would not give you, they will probably answer something else which is completely irrelevant to the question that what you're asking, or they are not able to uh, give you the correct answer for the question that what you're asking. And they may have a tangential thought process which is there. And when you are also looking at asking the patient for disorganized thinking, is when you ask the where they are and the what year it is or the day of the week, that all becomes part of the disorganized thinking. And feature 4 is the conscious level of consciousness. So either they are in the hyperactive mode or in the hypoactive mode. That's, yeah.
Thank you. Sir, last question. Vikas Anand is a postgraduate student from AIMS. He's asking about EPS, how to diagnose and manage EPS.
So they always have the extrapyramidal symptom in terms of rigidity, and they also could have certain eye signs that what we look at in EPS. And again, it depends from patients to patients when we are looking at extrapyramidal. And it's important to recognize that extrapyramidal is less when we use an atypical antipsychotics. Like for example, if you're using quetiapine, it's much less compared to haloperidol. But more important thing is to look for akathisia, where patients feel very restless, and they could have some features of dystonia or some dyskinesias, especially in the face. So this is some of the things that what to look for when you're doing. Yeah.
Okay, I think.
I think time is over now, with Arun.
Over. Thank you.
Thank you, Arun, and thank you, Naveen, for I think an excellent presentation full of evidence. And I think a lot of confusions and clearance is there about the treatment. And now it's time that we should create evidence from our side, uh, something like what works best for our patient and what does not work. Because today I think Naveen has given a lot of evidence and told a lot of. I think there is always a confusion when we talk about delirium, and I think a lot of clarity is there. Thank you, Naveen. And thank you everyone for joining. And thank you, Nisha, for keeping everybody on track. And we will see you next Monday before 6:30.
Yeah. Thank you, madam. Thank you. Thank you so much.